Welcome back to another MedTech Snapshot, the one question, one answer digest podcast. With me today is a good buddy of mine, Kevin. Kevin's the CTO of Revalve Solutions, based here in Irvine, California. And we're going to be getting into some discussions today talking about R&D's role with clinical development, as well as how you transition an R&D organization into an organization that's maybe a little bit more set up for that NPI scaling experience down the road. So stay with us. All right, Kevin, so we're diving in here on the clinical side of things, and I'll candidly admit this is not my forte, so I'm looking forward to getting some education from you here this morning on it. If you think about R&D's role as it relates to clinical development, can you walk us through how do you ensure from an Endeavor perspective you're successful in that area? When you look at things like procedural development, making sure that you and the team is utilizing the time in the clinic well so that you get to the back end, you have good data, and it's helping you actually move things forward. What are your thoughts on that?
It's a great question, Travis. R&D and ClinDev, they kind of go hand in hand, especially in early stage technologies. These are one and the same a lot of the time. If you're developing a brand new therapy, you're not just developing the device itself, but you're developing the procedure to go along with it. So as an R&D engineer, it really crosses both boundaries in the clinic. So one thing that I think is critical is really understanding what environment you're walking into. So for us, we're developing a transcatheter heart valve. We need to have a pretty intimate knowledge of what does a workflow look like? What are the standard tools? What imaging techniques are available so that you're not completely reinventing the wheel when you introduce this to physicians? You're hopefully doing something that they're already kind of accustomed to, and it makes adoption of that technology a lot easier. So I think that's kind of one aspect. The other one is when you're developing a new therapy, developing a new technology, just time spent is huge leading up to clinic. So as the R&D engineer, I would expect my team, and I did a lot of this early in my career, is be in the wet lab as much as possible, be in the animal lab, run through procedures, just rep after rep, because you're going to see things, even if it's just one-off experiences in these wet lab procedures that you're going to remember back to when you're in the clinic. So oftentimes, R&D, we support cases. It's device preparation, it's proctoring, whatever the other roles might be. And so being in the room, you're always going to run into things that are kind of unexpected. So the more reps you have back home, the more experience you have back home, it just prepares you and you feel a lot more comfortable so that you can take on kind of any issues you might run into once you're out there.
So what are some of the issues that you have seen people, or maybe even a better way to look at that is mistakes people have made when they're going into clinicals for the first time? Any thoughts on, what those mistakes are and maybe how you can avoid them?
Yeah. So kind of along the lines of the reps, getting the reps back home. I think one thing we like to do sometimes is we maybe discount findings that we see in the lab. So if you're in an animal study and you see an observation, it's very easy to chalk it up to, well, it's just an animal model thing. Or, our benchtop model is not perfect, so maybe that's a benchtop model thing. But really think about those things carefully and understand that, that could be a problem in the future. So how do we mitigate that when you go to clinics? I think that's kind of one thing, is the models aren't perfect, but still you can glean a lot of information from them. So I think that's one piece.
Well, that's good feedback, because what you're referencing there is confirmation bias, right?
Right. Yeah. If you don't want to look for a problem, you won't find one. So, let's be as careful as we can with the data we get, because there's so many unknown unknowns when you go into clinic. I think the other thing I would highlight is, as engineers, we like to perfect things. So I want to go into the lab, make the procedure, make the device rock solid, everything perfect. Then I'll show it to the physician and get their feedback. So that's a huge mistake. Let's involve our physician partners as early as possible, because they know what the standard practice is. They can give you really good feedback early on and kind of course correct before we get too far down the road.